Well, thank you. Thanks to Zach and Charles for getting me to Seattle, and it's a pleasure to be here. And thanks to the sponsors as well. I'd like to say that once more. We can't do this without your help, and I think all of us are thankful for it. So Zach asked me a few months ago if I could speak to the role of neoadjuvant radiation therapy for the care of patients with brain tumors. And what I'll show you today is a story that I think is very much just unfolding. And I'll put it in the context of a larger story that's been going on for about 20 years now, and that I think has really changed the way we think about caring for patients with metastatic disease. It's worth remembering that not long ago we thought of the development of brain metastasis as the end. And I think we've pushed for that no longer to be the attitude. And hopefully you've seen that with your patients. This has become a critical question because the burden that we see of intracranial metastatic disease in patients with systemic cancers has grown remarkably. And the players that we see now are epidemiologically very much the same cancers that we saw prior. If you look at most trials for patients with metastatic disease to the brain, these are trials with patients who have lung cancer, breast cancer, and melanoma. That's the primary of what we see. And if you think about places where we've really made advances in terms of taking care of systemic diseases, those three are a substantial population of them. Paradoxically, what that's meant for us is that we see more patients with intracranial disease. These are patients for whom we've developed targeted therapies that can control their systemic illness, and the brain ends up being a sanctuary site for disease. We know the incidence of brain mets is increasing. This probably has a little bit to do with the imaging that we have and the fact that we image patients earlier, but much of this is also simply that we control their systemic disease burden better than we did. I have a graduate student now who's doing an epidemiologic study with the strange hypothesis that we're much better at treating brain mets than we used to be. But patients die more often now of brain mets because we do such a good job of controlling their systemic illness. And that puts us, really, our community, in a position where we have to keep pushing ourselves to do better for that population. All of this started quite a long time ago. This is a trial that all of us know from Patchell and his group in Kentucky, looking at the role of surgery and really establishing the role of surgeons as caregivers for this patient population. We're looking here at Kaplan-Meier curves for patient survival and for local control. And these were patients who either received whole brain radiation therapy or surgery and whole brain radiation therapy in the setting of a single metastasis and relatively well-controlled systemic disease. And this showed very early on that we have a pretty substantial role as surgeons. We can do better for these patients with surgical resection than they would do with radiation therapy alone. And this has been shown over and again in multiple randomized controlled trials. So we have good phase 1 evidence that in patients who have a limited CNS burden of disease, and particularly 1 to 3 brain metastases, that our role as surgeons is one that can improve both their quality of life and their survival. Patchell actually pushed this a little bit further, and we don't talk about this trial as much, but it was critical. He asked, if surgery is such a good option for treating these patients, do these patients actually require radiation therapy? And the randomization process for this was slightly different. Again, this was the same population of patients who had a single brain metastasis in the setting of relatively well-controlled systemic disease. These patients either received simply surgical resection or surgical resection followed by whole brain radiation therapy. Remember, this is the days before radiosurgery. And what he found was that in patients who did not receive radiation following surgical resection, those patients have local recurrence, and those patients die of CNS disease. In other words, whole brain radiation therapy, or at least radiation therapy of some sort, wasn't something that could be taken completely out of the equation. It was a necessity. And if you look at all the numbers put together, if you do surgical resection alone, and our numbers may be better now that our surgical techniques are better, but about 50% of those patients will have a local recurrence within 1 year. In other words, surgery alone is not adequate to achieve local control of disease. This is really the first trial that changed the paradigm to include radiosurgery. And this was a large RTOG-sponsored trial, basically looking to see whether whole brain radiation therapy, whether local control and survival would improve with a stereotactic radiosurgery boost. This idea of boosting is something that's well known in the radiation therapy community and used in multiple other systemic cancers. The question was asked here. And indeed, what they found was that a stereotactic boost to the tumor itself could improve local control in patients who had brain metastases. Now, interestingly, one thing we don't talk about as much in this trial was that that additional boost improved local control. It didn't have an effect on survival. And this is something you're going to hear in my talk kind of over and again. And it has been very hard to capture signal that allows us to know when do we simply control CNS disease and when do we actually make a change in a patient's overall outcome. And that question has become more muddled with these radiosurgery trials than it was with the surgical trials, where it seemed very clear these patients do better with surgical intervention. That may speak to the fact that these trials are telling us about a population where we're finding evidence of brain metastases earlier. These are smaller tumors that we're discovering radiographically rather than tumors that we're discovering because patients are symptomatic from mass effect. And it may tell us about the fact that we're improving with their general systemic disease control. That trial, though, prompted the greater question. We know that whole brain radiation therapy has toxicities to patients. The brain is not treated well with whole brain radiation therapy. It has detrimental effects. Could we afford to treat these patients solely with targeted therapy to their lesions? And this trial really answered that question. This was a trial with a patient population with a limited CNS tumor burden, less than 4 brain metastases. Again, well-controlled systemic disease, and that's a critical part for all of this. These are patients where we've controlled their systemic disease well, and our goal now is to control their CNS disease. These patients either receive stereotactic radiosurgery upfront to the lesions or stereotactic radiosurgery and whole brain radiation therapy. It should be noted that these patients could receive salvage whole brain radiation therapy in the future and not be disqualified from study. But what they found was that the two were equivalent, essentially. In other words, survival here could be afforded to patients by achieving control of their CNS disease through stereotactic radiosurgery without an effect on their overall outcomes. And this was critical because it allowed us to think whole brain radiation therapy doesn't need to be considered as a first step in taking care of these patients. This was studied on a larger basis here by the European and American communities. And again, what was found looking at a very large population of patients was that we don't have to give these patients whole brain radiation therapy up front. I don't know how many of you have patients in your practice who are longtime survivors of breast cancer or longtime survivors of melanoma who've received whole brain radiation therapy. But you see a significant phenotype in those patients. These patients are cognitively impaired at the 5-6 year mark. This wasn't an issue when our patients weren't living 5 or 6 years, but survivorship now is a substantial matter. And many of these patients have long-term control of their systemic disease. if not even cure, despite having metastatic disease. And so this idea of saving them from the toxicity that comes from our treatments is not an insignificant one. And that idea that we should be treating not only to afford these patients survival, but to maintain function and to maintain cognition, you can see slip into the literature. And the date here, this is now 10 years ago. So this is, this really should be part of our culture. This was Chang and his group at MD Anderson, and Paul Brown did the same. But what they found, these are patients who have a limited CNS disease burden and relatively well-controlled systemic disease. Given stereotactic radiosurgery or whole brain radiation therapy up front, again, we've seen that there's no difference in survival in those two patient populations. And what these curves show, this is an interesting curve. These are actually neurocognitive curves. The patients who receive whole brain radiation therapy have a significant drop in their cognitive abilities compared to the patients who have targeted stereotactic radiosurgery. And this is not coming at a cost to survival. And so the burden really ends up on us that we should be treating these patients as if they have local disease rather than a whole brain disease. The answer for much of this is that at the moment, our goal should be to avoid whole brain radiation therapy in patients who have 1 to 3 lesions. And in fact, maybe you've seen practice patterns where stereotactic radiosurgery has even been used in patients who have up to 15 to 20 brain metastases. I'll direct you to this. This is from one of my partners in Toronto, Arjun Segal, who's been very vociferous in pushing this idea that our goal should be not only affording control of CNS disease for these patients, but maintaining their function. The literature is showing us over and again that stereotactic radiosurgery, targeted therapy, is functionally equivalent to whole brain radiation therapy in terms of achieving survival, and that we're able to do that without the cognitive cost that whole brain radiation therapy comes with. This, I think, has led to what I find now to be a really interesting evolution. And it took, if you look at the first radiosurgery trial, it was 2004. So it took almost a decade and a half for us to get to this point of remembering that we have a patient population who benefits from us as surgeons being aggressive with them. And now we have a radiation paradigm that allows us to avoid whole brain radiation therapy. And this idea of cavity radiation therapy is really what's being tested here. The notion here is that when we perform a resection of a brain metastasis, that resection bed will slowly collapse, and it leaves a cavity. Presumably, the nature of these cancers is that even though it's a solid tumor, there are tumor cells that have dispersed into the local brain. And in fact, if you look at why we fail in terms of achieving local control in patients with surgical resection alone, it's because they recur at that margin of resection. Again, presumably there are cells that are remaining there. Cavity radiation therapy works with that assumption. And after that cavity collapses, that bed is treated with stereotactic radiosurgery. And that's what this trial was looking at. Could we use cavity radiation therapy rather than whole brain radiation therapy to achieve local control? And again, what they found was an equivalence of these two. In other words, if you have a patient with a large brain metastasis that's symptomatic who requires surgical resection, we know that we afford that patient a survival benefit by performing surgical resection rather than whole brain radiation therapy alone. We know from prior data that that patient will have local recurrence without some sort of radiation therapy, and now this is showing us that rather than giving them whole brain, we can give them a cavity, local radiation therapy. This is from my group in Toronto, and what we found in a large experience of treating these patients is that there's something about that surgical resection bed. It's perhaps more friable because of recent surgery, that we were finding high rates of radiation necrosis complicating those patients, as well as high rates of local leptomeningeal disease, and I'll show you that in just a moment. But we've moved from doing single-dose SRS to hypofractionated SRS as a result, with good results. And this is kind of getting into the technical nuance of it. But what we found is that after you've performed surgical resection, these cavities that form are often very irregular, and the dosimetry is easier for us, at least we found, using a hypofractionated approach rather than using single-dose stereotactic radiosurgery. And we've shown we've been able to do that with better efficacy than using single-dose alone. We're getting towards what this idea of neoadjuvant RT may be now. So I'm going to show you a patient of mine. So this is a lovely woman I met last year, 37-year-old woman, triple-negative breast cancer, so an aggressive phenotype of peripheral disease. She'd had slow progression of her systemic disease and then presented with 3 weeks of headache and slowed cognition, and she had this large metastasis. And you can see there's some complicated things about this metastasis already. It looks like it is parenchymal, but may be seeding the subarachnoid space. Already you can see the relationship to the ACAs. But I took her to surgery, and I was pleased with the resection that I performed. But this is what her scan looked like 3 months later. And you can see some of the classic findings that we see of leptomeningeal disease. And you can see that she's got this deposit back here near the fourth ventricle. But you can see all this here, which was without doubt. I took an interhemispheric approach, and without doubt that was spillage that I caused simply by the fact that it was a large tumor and one where I couldn't resect it en bloc. So this phenomena of a local leptomeningeal process complicating surgical resection has now been well described. This was a recent paper in JAMA Neurology. They looked at a large database, about 1,200 patients who'd undergone surgical resection for intracranial metastatic disease, and they found that about 15% of patients, 15%, so quite a large burden, developed this sort of leptomeningeal dissemination. And interestingly, it doesn't look like the classical lepto that we typically see. Much more like this, where you could imagine the mechanism here is that we have locally seeded tumor cells. So that leads to this idea of preoperative radiation therapy. So what would neoadjuvant radiation therapy mean? So I'll say our experience has been pretty limited. We've only done this in about 50 patients so far. But what we do is identify patients who we think of as high risk for that local seeding. That first patient I showed you, it's because it's a large tumor that's already exposed to the subarachnoid space, and one in which I knew that I wasn't going to be able to perform an en bloc resection. I will often do this with posterior fossa masses that are large as well. But the notion here is that that preoperative setting gives you an opportunity to radiate the tumor when the contours are well defined. Now, what's the issue here? There's a reason we're not treating these patients with stereotactic radiosurgery. They have large symptomatic lesions, and the worry is that radiosurgery could push them over an edge. For us, what that has meant is these are patients who have SRS, followed the next day by surgical resection. This is very typically what it looks like. You can see we end up doing contouring very much like we would for a normal SRS scheme, and then these patients go to surgery. I'll show you just one case. This is a 52-year-old gentleman. He had an abdominal mass identified during workup for postprandial pain, diffuse retroperitoneal lymphadenopathy, had a biopsy of a stomach mass that showed a HER2 positive gastric adenocarcinoma. He responded very well to systemic chemotherapy and Herceptin, and then presented with acute hearing loss and gait unsteadiness and had this lesion here. In my mind as a surgeon, what I see is a lesion that is, again, coming into the subarachnoid space and too large for me to resect en bloc. We took this patient for stereotactic radiosurgery, and then he went the next day for surgery. The idea here is that I'm still going to seed these tumor cells just by the nature of what I do. We're going to have spillage of tumor cells into the subarachnoid space, but those cells will have been treated. Remember, the effective radiation therapy is a long-standing one. The preoperative setting allows us a time where those cells are all confined to the tumor mass and where we can capture them. We're not able to do the same after surgical resection. So this is a significant issue for us. Our colleagues from oncology are getting better at treating these patients, and we've got to continue to do the same. It's something we have to remind each other not to be nihilistic about. And as we become more refined in what we do, we're going to have to think about our role not only as keepers of well-being, but of function. So on that, I'll take any questions that you might have.
Great talk. I'm supposed to remind people when they get a question to press the mic button. Great talk. I think that's a really good strategy. We have started using the radiation prior to surgery approach as well. Occasionally we'll have a case like one we had recently where it was really superficial. I think in those cases, the surgical healing, wound healing may be difficult. So I was going to ask you your experience on that, if you've had any trouble with that.
So we've been fortunate so far. I'll say we've been very selective in the way that we've approached this question. And it's unfortunate because it's compromised the way that we're able to study it because it's been a very focused population. We haven't had a complication yet, but it's something that will happen at some point. I'll say this has involved a very coordinated, cooperative approach with my colleagues from radiosurgery. And I showed Arjun's paper earlier, and it's been very much a program that I've built directly with him. This is to coordinate which cases it's sensible to take this approach and to coordinate between the radiation treatment and surgical resection has been critical.
Sunit, you mentioned the trend for postoperative therapy of hypofractionating to avoid some of the complications that you can see with treating the traumatized tissue at the margins. So for preoperative or neoadjuvant therapy, are you reverting back to single fraction, or is it a 5-day course and then on day 6 they go to surgery?
No, so we've done single fraction so far, simply pragmatically without knowing kind of if we could get away, frankly, with doing hypofractionated. Our fear has been, I think the general fear, that you have someone who's already symptomatic. Are you going to tip them over an edge by treating them preoperatively? We've slightly underdosed these tumors, and that may come back to be a problem. Again, I don't have the data to speak to that yet. I know there's a talk coming up on leptomeningeal disease, and I think that will be critical for us to figure out. Does this actually diminish the risk of that complication?
So we struggle a lot with insurance approval in a rapid fashion to be able to get to the radiosurgery, the much of an issue, but
Yeah.
have you found that also to be a limiting factor in adulting using?
I would advocate for a single payer system, which is spectacular for doctors and patients. That's as political as I'll get today with that. No, we don't have that issue.
Hi, I'm Patty Kwok. I run the survivorship program. What's your experience with pre and post neuropsychology testing?
So that's a great question. It's we do have difficulty finding it as a resource to be able to give to all patients. And I'll say in the end, it ends up being an out-of-pocket expense for us. That means that wealthier, more educated patients tend to be the ones who we study. We don't have data for neoadjuvant RT yet, but we've got good data in both glioma patients and brain metastases patients that tumor control, it looks like, is actually the most critical thing in terms of maintaining cognitive function. If we control the tumor without causing iatrogenic harm from our treatments, people stay relatively well.
Sunit, do we have any data, or can you hypothesize? I know we have one neuropathologist in the audience. The effects of pre-treatment radiation on the post-operative histopathologic and molecular pathologic evaluation.
I will have the paper for you in about 7 months. Charles, thanks so much.